This is a brief summary of the management of a postpartum hemorrhage. There will be 4 learning objectives. The first will be that the nurse will be able to identify the risk factors for a postpartum hemorrhage. She will effectively and efficiently allocate resources to manage a postpartum hemorrhage. She will be able to adhere to policies and procedures concerning management of a postpartum hemorrhage, and she will be able to accurately document the events that took place during the hemorrhage. It's estimated that 500,000 women die due to pregnancy worldwide every year, which is a very high number. 25% of these deaths are due to a postpartum hemorrhage. Hemorrhage is the most common cause of maternal morbidity and mortality, and it can occur in 1 to 5% of all deliveries. One of the most important things to do when being proactive is to assess your patient and to identify who is at risk for a postpartum hemorrhage. Women with over-distended uteruses, which are usually women who have babies who are larger than normal, or who have more fluid than normal in their uterus, have over-distended uteruses. Any woman who has a high parity. These are moms who have had 3 or more children and whose uterus is just getting a little tired now. Prolonged labor. Any labor that lasts for more than 12 hours, the women are at risk for a postpartum hemorrhage. Precipitous births. Any delivery made within 3 hours of the start of labor. Uterine atony in any previous pregnancy is a red flag for a postpartum hemorrhage. If the uterus at one time was unable to contract and become firm, it is more than likely that it would do so again. Any woman who has had a history of a postpartum hemorrhage is also at risk. Choreo, infection after the membranes rupture, can also cause a woman to hemorrhage after birth. Abnormally adherent placenta, such as placenta accreta, increta, or percreta, and any bleeding disorders. Some of the main causes of a PPH are uterine atony. That makes up about 50% of all postpartum hemorrhages. And that's basically that the uterus just cannot contract back to its normal shape. Lacerations. Sometimes the provider can miss lacerations, and that can cause the bleed, where these vessels continue to bleed and cause the hemorrhage. Retained placental fragments. The inversion of the uterus. Sometimes when the placenta is pulled on too roughly, it can cause the uterus to invert and cause a massive bleed. And placenta accreta, which is when the placenta embeds itself too deeply into the uterine wall. And of course, hematomas. One of the most important things to remember when dealing with a postpartum hemorrhage or when working on a labor and delivery floor is that at the beginning of the shift, everyone should have specific roles and assignments. So your blood runner should be identified. Your the nurse who's going to document events should be identified. Anyone who's going to run for supplies should be identified. This can this can really help save time during the management of a PPH. Knowledge of where supplies are and where they can be found is very important. Gathering your team. Knowing who your team is and knowing how to locate and get them to your area quickly is very important. And situational awareness. It is important for everyone to be on board and to be able to respect each other's perceptions of the situation. If someone is not comfortable or is concerned about any situation, then action should be taken. Policies and procedures should be adhered to when dealing with a PPH. My policies and procedures come from Health and Hospital Corporations of New York City, and one of the policies is that every patient that comes into our unit is carefully assessed, and their history is assessed for any potential risks. We never leave a bleeding patient alone. We will yell out of the room or we will use the phone, but we will not leave the room, and we will make sure that we have enough staff to where we can support that patient. We call for help and monitor vital signs every 15 minutes. We observe for signs and symptoms of shock. We notify the attending immediately. We massage the fundus until it becomes firm and expel clots. We administer volume expanders and blood as ordered, which is why it is so important to identify a blood runner at the beginning of the shift. This way, once blood is ordered, you have someone who is going and getting the blood as needed. You should be securing additional IV access just in case blood transfusions are needed. You should observe for the increase of fundal height. This increase could mean that the uterus is filling with blood. And measure the estimated blood loss. Sometimes providers and nurses are in denial, and they do not estimate the blood loss accurately because they do not want to believe that the patient has lost that much blood, and that can really be detrimental to the patient's health. You should maintain the patient warm with blankets, and once the situation becomes uncontrollable, once you have a bleed that is active and is not being managed well, an OB-STAT should be called in order to get an entire team together and take the patient to an OR for further examination and management. Documentation is one of the most important things that a nurse can do during a PPH. She should be recording time, participants, procedures, medications, and the overall outcome of the PPH. This documentation doesn't only record what has happened, but it can also be used for any improvements that can be done for the management of future PPHs.